the revision case presentation with the different strategy. Previously, sir has already discussed some strategy regarding the salvage of the broken balloon. Here, once in the night, that was the emergency patient, 36-year-old male, chest pain for 2 hours. This is just post-Valentine Day patient at the night time. And many person of us had thought some kind of the broken heart, but that's okay. He was a chronic smoker, tobacco chewer, and not written here is he had taken so much of the alcohol at that night because of that heart breakage. Okay, so now at the time of the presentation, heart rate was 96, relatively stable, but BP was just on the verge of the sinking. 90/60, SpO2 96. We have taken, we are considering this a kind of routine case. So this was the angiography. RCA was quite normal. Here we can see the LAD is almost involving the ostium. In this patient, we started the procedure, put the wiring the LAD, then ballooning the LAD. Things are going smooth till now. Now, you can see after the first balloon, I am getting the flow, but still there is some kind of the thrombus is there. So that's okay. Let's do balloon again, and this time keep it inflated for some more time. Now.
This balloon, see, you should be very careful. It's a large, bulky thrombus sitting very close to the LM bifurcation. The only thing or the only direction which it can go is circumflex. You should be very, very careful here.
Now, here, while inflating the balloon second time, here you can see there is some dye flowing while inflating the balloon. So at this point of the time, we come to know there is some issue with the inflation device. First, we all thought there is some, because the pressure was not rising on the inflation device, and I am showing the dye flow. After that,
your shaft of the balloon has ruptured. Yes. Yeah. That's why the dye is leaking through the shaft, yes, through the guiding catheter, into the left main, and LAD is getting blocked, is going into the circumflex.
Yes. The shaft of the balloon was fractured, means it was broken. And the issue in that was because it was a partially inflated balloon in the LAD, and it was restricting the flow and not able to pull out with the assembly. At this point, we have tried to, means the part of the balloon was still in the catheter. So we were thinking about, there are 3 to 4 options were there, because we can pull out whole assembly, but balloon was partially inflated. Second, flow is restricted in the LAD. Third, any other hardware, means if I try to introduce the guide liner or any other, that was not possible, but balloon is still on the wire. Now, the possible retrieval method as per complication, this one could be the snare capture, then the helix technique with the multiple wires, and trap with the guide extension, and or trap with the balloon. Here, the possible scenario for this patient was snare capture is not possible because I am not able to localize the proximal end of the balloon. I am not knowing where is the proximal end. Most probably it is in the catheter, but I cannot decide where, at which point exactly it is there. The second point, helix technique, it is not much useful because of the inflated balloon. It is less likely, this is around 275 balloon, and it is less likely to catch that balloon. So we were going to do the step by step. First, I had crossed second wire, then while I have pushed that balloon, inflated balloon, distally, because I was not trying to hamper the proximal LAD. The occlusion in the proximal LAD leads to hypotension and everything. Then I have crossed, I have done the sequential balloon with starting from 1.5 to 2.75 along the side of the broken balloon. That lead to deflation of that balloon. And that established the flow. After that time, I have some time to think how to retrieve this balloon, because here in this shoot we can see there is a flow till the distal LED is not compromised. I am achieving the good flow. So the technique came to rescue me was, which sir has discussed in the previous our last discussion. Here, I have inflated almost same size 3 mm balloon along the side of that broken balloon after crossing the broken balloon, and pulled that balloon partially inflated. This is 4 to 6 mm partially inflated balloon, and pulled whole assembly, whole balloon and wire along with in the guide. And I was successfully able to pull everything out into the guide. After that, here the balloon is still partially inflated while pulling out the whole assembly, because there was a chances of the embolization, and whole assembly is pulled out while keeping the mouth of the catheter shut, or the partially inflated balloon. After that, I am achieving the good flow in the LED, and ECG and everything was the settle. So take home message or the discussion for this patient was, first thing, don't panic and pull everything. Well, I have got this situation, the first response for me to pull out everything. Means if I put the catheter, the balloon and everything, whole assembly will come out, but that may make me lose my access, the only access. Then if the free end is available, the snare is useful. But if you cannot see the free end, you won't able to catch from where you want to pull that thing. Second, trap balloon, if free end is not available, in that case, in this case, I can have tried trap balloon while trapping in the catheter. But that also was not useful, because I was not sure which part is still in the catheter and how much it is still in the catheter. Twisting wire was not useful for this method, for this case. Risk of device embolization is always there, and I have preventing embolization, I have keep the balloon partially inflated at the end of the case.